So good evening and welcome to our second webinar for National Mentorship to Medical Students Interested in a Surgical Career, hosted by the American College of Surgeons. My name is Steve Yang. I'm the chair on the Committee of Medical Student Education for the ACS. I'm also a professor of thoracic surgery at Johns Hopkins. I first want to thank you all, the students, and perhaps some faculty for coming on to this webinar this evening. We've had an extremely overwhelming response in the number making reservations to this webinar, and we were oversold on our first webinar 5 nights ago. And if not already done so, please answer the polling questions so it will provide some direction to our discussions tonight. We want to make this as interactive as possible to benefit you all. So during the course of all the talks this evening, if you could put your questions in the chat bar, we'll try to answer as many as we can. We know normally during this time of year, students are full of excitement, preparing for their next year, looking forward to clinical rotations, and perhaps planning some sub-internships. If that were not enough of a difficult process, the pandemic has undoubtedly added unnecessary stress, many complexities and obstacles this year. We hope to provide some general guidance and hope to allay some fears. If your institution is like mine and you, the students, will be welcomed back to clinical rotation soon, make sure you go back with a new sense of purpose. Thank the many volunteers. Be tolerant that patient care is not the same, and take advantage of the many innovations your faculty have made to restore some normalcy in your curriculum. Many students will fear contact with COVID patients, but remember, as we think back and decided why we chose this medical profession, we really want to help our fellow humankind no matter the situation. On this panel tonight, we have the leaders in surgical education who bring their different experiences and perspectives to the process of residency application and also for mentorship. Before I ask the panelists to briefly introduce themselves, I would like to personally thank Dr. Sachdeva, Director of the Division of Education for the American College of Surgeons, an icon and figurehead in surgical education, and has devoted the past quarter century, particularly in developing programs like this specifically for medical students. And not on the panel tonight, but always virtually around, is his Associate Director of the Division of Education, Patrice Blair. So we thank them both for this opportunity tonight. I'd first like Dr. Sachdeva to make some introductory comments.
Thank you very much, Dr. Yang, and welcome to everyone on this important webinar. As Dr. Yang has mentioned, this is our second in a series of webinars aimed at medical students. And our aim has been and still is to help students prepare for careers in surgery, and to provide them the tools, whether it is an educational program or guidance or mentorship, so that their transition into residency training is smooth and they enter the programs well prepared. Obviously, the challenges that have been associated with the COVID pandemic have changed a lot, and they have really stretched our imagination in a way, and we have been looking at different ways to do things and to support the career aspirations of medical students. Throughout all this change, what has remained constant is our commitment to our patients and our passion as surgeons towards the profession of surgery. We are delighted that you are interested in this field. We hope many, if not all of you, will join the surgical profession, and we hope that you'll find this webinar of value. We look forward to your comments, and I would like to thank the faculty. Special thanks to Dr. Yang for organizing this webinar, and also my sincere thanks to our staff who've done a fabulous job in supporting this activity. So we hope you find this webinar helpful and look forward to your comments, suggestions, and a very exciting discussion ahead. Thank you very much, and I'll turn it back to Dr. Yang.
Thank you, Dr. Sachdev, again for your kind comments, your mentorship and leadership. I'd next like to invite the panelists to briefly introduce themselves and perhaps a few sentences on what they represent and why their perspectives would be important tonight. So I'll start with Dr. Moore.
Hi, good evening, everybody. My name is Dr. Jesse Moore. I'm a colon and rectal surgeon up here at the University of Vermont Medical Center in Burlington, Vermont. I was the clerkship director for about 5 or 6 years here, and very involved now in undergraduate medical education as the director of active learning, and recently was the chair of the Association for Surgical Education Clerkship Directors Committee. So I do a lot of advising. I've worn a lot of hats in undergraduate medical education. I'm going to be trying to bring the clerkship directors and the advising perspective to this conversation tonight.
Thanks, Dr. Moore. Dr. Sudan.
Good evening. My name is Ranjan Sudan, and I'm professor of surgery. I'm also the vice chair for surgery at Duke University Medical School. And I've served as the past president for the Association for Surgical Education. I have served as a consultant for the American College of Surgeons and looked across all of the curricula that are offered for medical students and residents. I will be focusing on presenting those curricula to you, so you may have access to the resources that will help you be successful as medical students and potential future residents.
Thank you, Dr. Sand. Dr. Choi?
Hi, I'm Jennifer Choi. I am the program director at Indiana University. I also am a bariatric and minimally invasive surgeon, and finally I'm attempting to parent the last week of school for my kids. So if you see some extra faces pop in, that will be why.
Well, we look forward to seeing them, Jen. And last but not least, Dr. Schnartz.
Hi, I'm PJ Schnartz. I am the vice chair of the Committee on Medical Student Education for the American College of Surgeons, and also a past president of the Association for Program Directors in Surgery. While I'm not speaking specifically for that organization, I think Dr. Choi and I are trying to achieve today is to give you a little viewpoint on what program directors are thinking as we approach things like letters of recommendation, your timing of your USMLE scores, and other sort of things that from a program director's standpoint. And finally, I'd really like to, I understand we have quite a few of the MS1 and MS2 students. Surgery is a fabulous career. I'd keep all your options open, but I'll tell you, I haven't worked a day in my life since I became a surgeon. Not that days aren't hard, but it's a heck of a lot of fun. So welcome, and hopefully we can answer your questions for you.
Great. Thanks, PJ. So as I stated earlier, I'm a general thoracic surgeon. I've been at Johns Hopkins for 26 years. And my career has shifted from being basic science to mainly clinical, but then I drank the Kool-Aid to do a lot of surgical education. I was the clerkship director for Hopkins. I also played a role with the Association of Surgical Education with the clerkship directors. Currently, my role, in addition to working for the Committee on Medical Student Education for the ACS, I'm also on the American Board of Thoracic Surgery as one of the directors and on the Residency Review Committee for Cardiothoracic Surgery. So I bring maybe a little bit of a different approach from a subspecialty, probably the only member above the diaphragm tonight. And so any subspecialty questions I will also try to field. So I would also, as Dr. Sachdev said earlier, I would be remiss if I didn't acknowledge the hardest working staff of the American College of Surgeons. Kim Eschert, Brad Aiken, Sangham Ratsavang, and Olivier Petinoff for their immense work in setting up this webinar. They've stayed up late almost every night for the past 2 weeks trying to get this organized and sending out emails to ensuring the smoothness of the Zoom meeting. I know this might be getting old, but indeed these are challenging times, unprecedented in our lifetimes, but not in our history. Many have brought how we overcame the pandemic 100 years ago. We too will endure. Many favorite surgical euphemisms come to mind. Adapt and overcome. Change is good. Chaos brings opportunity. The constraints you currently face, lack of personal face time with mentors, inability to do specific rotations, limited available required rotations, distant patient contact, deciding on the surgical specialty, or even if you want to be a surgeon, are all the solutions all of us on this panel, along with our national colleagues, are ensuring to solve for you. Thus, we felt the need to do this webinar now, just as this pandemic came on and the future is a little bit unclear. We may not have many definitive answers, but we are working hard to find solutions, but mainly want to keep all of you, our surgical future, engaged and inspired. So despite the social distancing and remoteness of this meeting, we would like to be as interactive as possible. As I said earlier, if you just joined us late, make sure you send your comments into the chat room, and we'll spend plenty of time answering those questions at the very end. So the goals of tonight's webinar is to provide advice and guidance at a national level to medical students pursuing a career in surgery. And our objectives are to review current process and challenges students may encounter in preparing their applications for surgical residencies and even looking for surgical rotations, provide some online curricular resources to supplement your home institutional curriculum, and to discuss changes to the national residency application pathway at a national level. And so without further ado, we'll get the program started. So I'd like to again introduce Dr. Jessie Moore from the University of Vermont and past chair of the Clerkship Directors Committee for the Association of Surgical Education. Jessie.
Great, thanks, Dr. Yang. Okay, so I'm going to take control of the mouse here. And all right, so it looks like about 2/3 of our participants, just about, or a little bit, about 140 of you are either about to start your third year or have just finished your third year. And so this part of the talk is mostly going to be aimed at those of you who are thinking about applying for surgery either after your clerkship or right now or in the middle of the process. So. All right, let me see if I can advance here. Hold on one second. I've got a little laser pointer, but I don't seem to be able to, can't advance it though. Oh, so there we go. All right, let me just try that again. Okay, so we're going to talk about which parts of your application matter the most and how COVID-19 has impacted those. And we'll also talk about the typical timeline for applying for surgery or for any residency for that matter, and how COVID-19 is impacting that. So we're going to specifically talk about your STEP scores, surgery clerkship honors, letters of recommendation, and then the interview. And we're going to really try and focus on how you can optimize those factors. A lot of this data and what I use to advise my own students comes from the National Residency Match Program Director Survey. So every other year in even years, the NRMP, after the completion of the match, surveys all the program directors and puts it together and sends it out, and it's available to everybody. And so you can get a little bit of a glimpse into how the sausage is made from the perspective of the different programs. So this slide shows data from general surgery program directors, 100 of them from 2018, and that's the most recent data that's out there. And this is the factors and how important each factor is for the program directors when they're trying to select who they're going to interview. And what you can see is that the top factor is step one. And that's no surprise. It's the one thing that every single student in this country takes. And so it's the one objective uniform assessment. And so it becomes a pretty handy sorting tool for a lot of program directors. Step two is also pretty important. You can see that about, let's see, 2/3 or about 70% of program directors require that there's a step two score. So how does that have an impact now given the COVID? Well, if you're a student who has not taken step one, I think that this data demonstrates how important it is. We recognize that there's just been a change in a recommendation that the score will become pass-fail. We have no idea when that's going to happen. I think when that does happen, for those of you who are first-year medical students, what that likely will mean is that step two becomes more important for program directors. For those of you who have already taken step one, good news is that COVID doesn't change your score and can't take away that score for you, so that is what it is. Your step one score does have some impact on how you should be thinking about taking step two. What I usually advise students is that if you have a well above average score for general surgery, then you can wait and do rotations, acting internships, and sub-internships earlier in your fourth year, get good letters of recommendation, and you can do your step two later on. You don't need to prove anything if you have a really strong step one score. If you have an average step one score, then I would recommend that you take step two towards the middle of your summer so that you can get a score back. It usually takes 4 to 5 weeks to get a score back, and that'll help you and whoever's advising you think about which programs to apply to so you can be the most competitive applicant. Similarly, if you have a below average step one score, then you need to take step two as soon as you can get a spot basically on their schedule so that you can get that result and you can see how you did. If that score is still below average for step two, then you're going to need to probably have a backup plan for applying for general surgery. If you can get it to go up a lot, that's great, but then you need to use that data along with your step one and the rest of your application to think carefully about where you apply. There's always a lot of questions every year from students that I advise about the impact of honors in surgery. And these are still the same data from the program director survey. And what you can see is that grades in the clerkship in your desired specialty is kind of middle of the pack here, okay? So for those of you who maybe have already done your clerkship, don't panic if you didn't get honors, that's okay. Nationally, about 30% of students get honors in a surgery clerkship. That doesn't mean that those people who didn't get honors in a surgery clerkship have no chance. You do, you're fine. Plenty of students, most students who apply for surgery don't have honors and do just fine. For those of you who have not done your clerkships yet and are about to start that, we know that a lot of medical schools around the country right now are grappling with what to do with how to grade students going into the clerkship. The clerkship year is going to be very different because of COVID. There's going to be less time for the rotations, less opportunity to work with faculty. Faculty are going to be stressed and so forth. So a lot of medical schools around the country are moving to making it pass-fail. That will certainly be noted in your school's what's called your MSPE or your dean's letter. And so the program directors will know whether or not you were if you were pass-fail honors or if you were just pass-fail. And similarly, program directors are aware of how much things are changing. So my take-home message here is work as hard as you can, do the best you can, have the most fun with the rotation, but don't panic if your medical school is moving to pass-fail. Letters of recommendation, these are really, really important. So if this top figure is the same one that you've seen before in terms of factors that program directors use to select applicants. And what you can see is that after step one, which they use as that sorting tool, the next thing they usually look at is those letters of recommendation. Those are really, really important. When it comes down to how they actually rank applicants that they've interviewed, interview factors become really important, but letters of recommendation is still right up there. So this is something that's really important, particularly if you're thinking about applying for this cycle. So how do you get a good letter of recommendation? Well, first of all, you should target trying to have about 3 or 4. That's not a national number, that each program has its own requirements, but I think if you have 3 to 4 letters that you can use, then that's going to suit you well. I have an asterisk next to anything that is impacted by COVID. And so again, program directors this year are going to understand that students have had potentially less opportunity to do acting internships or sub-internships. And so they may not have as many letters of recommendation. I feel strongly that faculty at your institution are going to write you a better letter than a faculty member from another institution if you're doing an away elective or what's sometimes called an audition elective. Your faculty are invested in your future and you having the best chance going forward. Generally speaking, these should come from acting internship or sub-internship faculty, not usually from faculty in the clerkship. There are going to be some exceptions to that this year, I think, when, again, you just don't have the opportunity to do as many acting internships or sub-Is. And so substituting in a letter from a faculty member you worked with on the clerkship that you had a really good relationship with is okay. Generally speaking, it's still not a good idea to have it come from a resident. This needs to come from a faculty from your College of Medicine. And certainly research and community faculty can write fantastic letters. If you are somebody who's really interested in applying to programs that are heavy on research, and you've done a bunch of research and worked with a research mentor for a couple of years, and they can really speak to your capabilities, then having a letter from them is totally fine. Similarly, a community faculty member who really knows you well can write a fantastic letter. And what you really want to have is a letter that can speak to who you are going to be as a resident and ultimately as a surgeon. And how do you get that? Well, you're going to identify those faculty early on in the acting internship. You're going to work your tail off. Okay, you're going to go to every single one of their clinics. You're going to go to their cases. You're going to make sure you round with them. And when you round with them, you're going to know everything about their patients. And then the real secret to getting a good letter of recommendation is to work really, really hard for the residents. If you work hard for the residents, what usually happens is that the faculty member at some point when you're not around, usually when they're operating with the resident, they say, hey, how's that student, how's that acting intern doing? And if the residents say how great you are and that they would love to work with you for the rest of their residency, that means a lot to faculty. Generally speaking, you want to try and ask in the 3rd week so that if you're not already kind of on their radar as somebody who's going to ask for a letter, they know that, and then they can pay particular attention to how you do for the last week and a half or so. Okay, the interview, really important when it comes down to selecting who to rank for programs. Everything else falls down below, the top 4 things now are all related to how you do on the interview. So we've already talked about how you can make your application as strong as possible. So how do you get interviews? Well, it starts with where you apply. You have to really determine your goals. Please try to resist the temptation to think about programs based on name recognition. It does not matter what it says outside of the hospital on the wall. It really matters what kind of program it is and how it prepares its residents and how that aligns with your goals. If your goal is to be a community surgeon, then you don't need to go to one of the, highest NIH funded surgery departments in the country. That would be a total mismatch. You need to really be honest about your qualifications. You need to have an advisor. And for those of you who are early on in this process, hooking up with an advisor is something that's really, really important to do. Meet with them every couple of months. Think about doing research with them. A great way to try and find an advisor is to figure out who your clerkship director is at your College of Medicine and email them and say, hey, how do I get an advisor? I'm trying to think about whether surgery is right for me. And think about if you have an opportunity this summer, if it's possible, given COVID, maybe try and do some shadowing. But spend some time with surgeons. Eventually, you're going to have to pick about 25 to 30 programs to apply to. I usually say 2 to 5 should be your reach programs, 15 to 20 that are more realistic for you, and then 2 to 5 that are safety. And plan on about 12 to 17 interviews. It logistically is hard to do more than that in person. Of course, this year, I think we're going to see a lot more use of virtual interviews, and so those numbers might change some, although I think it's unlikely that the overall number of interview slots that programs are offering is probably going to stay about the same. Audition electives. Everybody, I think right now is really panicked about the inability to do audition electives. And what I want to do is reassure you that I think that that's okay. Away electives, when it comes down to selecting applicants to interview, it's just not that important in general surgery. And this is very different than in some of the subspecialties. So some of you may have colleagues who are applying for ear, nose, and throat or orthopedics, and they're really panicked. And that's for a different reason. It's much more important for those subspecialties. But for general surgery, it's just simply not that important. So I don't think you're at any disadvantage. It's even less important when it comes down to ranking applicants, okay? I think you should do an audition elective for 2 reasons. One, you want to have an adventure. You want to go someplace and see something that really intrigues you. Often our students up here in rural Vermont, they've rotated on the trauma service. They've had a lot of fun, but we don't do a lot of operative trauma. We have a lot of blunt trauma. So I encourage them to go to a Cook County or to a Ryder down in Miami and do a ton of penetrating trauma and operate all night. Have an adventure. The other thing is if there's really an area of the country that you're interested in exploring, if you're a kid from the Southwest, not real accustomed to snow, and you're not sure if you want to be where it's cold, come to Vermont in December. It'll probably snow and you can figure out if you want to be up here for 5 years. So those are really, to me, the 2 reasons to do an audition or rotation. Lastly, I wanted to show you the typical timeline and then how that has changed because of COVID. So this is the typical timeline. And right now, we're encroaching on June rapidly, and normally students would have been already doing their acting internships and will have been taking step 2, thinking that ERAS is going to be open to programs in the middle of September, and then the dean's letter comes out October 1st. And then interviews typically happen in November, December, and January. Well, that's going to change. So obviously we've already all seen that things have changed on the front end because most of you are pulled out of clinical rotations right now. Most are going to be starting those in June or in July. The other big change that we have seen just in the last 2 weeks is that ERAS is going to delay opening for about 6 weeks, and it's going to be a simultaneous opening to programs and to have the MIS be released. So that's good because that creates more space for you all to be working on your applications, getting your AIs done, getting your step 2 done. So being able to really put together a more complete package since you've had your time curtailed on the front end. That is going to have an impact on how much time the program directors are going to have to review their applicant files, decide who to interview, and then offer interviews. So the interview season may end up being a little bit shorter, but again, I think because of the use of virtual interviews, it probably will work out for you. So that is the end of my discussion, and I look forward to hearing from y'all later.
Okay, great. Thanks, Dr. Moore. Next, we have Dr. Sudan from Duke University to talk about online resources.
Thank you very much, Steve. I noticed that we have medical students who are at many different stages of their career through the medical school, and this will hopefully have something for everyone. And the first thing that I wanted to talk to you about is the educational resources for medical students. So if you go to the American College of Surgeons website, this is a good place to start because this gives you many different curricula. It also talks about what the lifestyle of a surgery faculty member is, or how you should go about selecting a surgical residency, etc. So this is a very good page that gives you many different landing spots. One thing that you should remember is that this was written in the pre-COVID era, and as Dr. Moore described, there are some changes that have taken place of necessity due to this COVID pandemic. And so you should just keep that in mind and adjust kind of your thought process accordingly. The next thing I wanted to cover with you is the American College of Surgeons Association for Surgical Education Medical Student Core Curriculum. This is a curriculum that was written by surgeon educators, and it was written for a student who should know kind of the basics of surgery regardless of their career destination. So it doesn't really matter as to which field you are eventually planning to go to, but these are the essentials that you must know. This is not encyclopedic. It has well-defined goals and objectives, and I'll talk to you a little bit more about that and as to how to access it. I'll also talk to you a little bit about the medical student simulation-based surgical skills curriculum, and then the introductory cases for the American College of Surgeons Fundamentals of Surgery curriculum, and finally, the online guide to choosing a surgical residency. We also have a prep curriculum that I'll spend just a minute or two talking about. Can you please advance my slide, Brad? Thank you. Got it. So this is the American College of Surgeons Association for Surgical Education Medical Student Core Curriculum. If you click on the link, it will take you to the website that gives you this curriculum. This is nice in the sense that it has all of these modules that are currently available. It has well-defined goals and objectives. So the goals and objectives are a page and a half long, and they tell you all of the things that you must absolutely know about this particular topic. We have selected this to be symptom-based as opposed to organ-based or disease-based, just because this is the way patients will present to you, either in the emergency room, on the consult service, etc. So this gives you kind of a nice framework to evaluate a symptom-based presentation. There's also content that is associated with it. The content actually addresses all of these goals and objectives, and this is written specifically to address the needs of a third-year medical student, again, regardless of their career destination. Given the fact that there is pandemic and there's a lot of variability in presentation of curricula, even within sites and across the country, one of the things that we are starting is web-based seminars This will start in June, and it will address all of these topics. It will be offered in an evening time, so I recommend that you look forward to those announcements and then try these seminars so that these will be nice supplemental material for what is being taught in your clerkship. One of the other curricula that is offered, again, it's a combination effort from the American College of Surgeons and the Association for Surgical Education, is a simulation-based skills curriculum. This skills curriculum is good for students at all stages, all the way from MS1 through MS4. You can pick and choose what module you want to learn. It is structured, it is uniform, and it gives a consistent learning experience. And it includes items such as how to do a good abdominal exam, all the way to how to perform a central line placement. So if you follow this curricula, then you'll have a very good basis to the skills that you should be learning as you go through your medical school. One of the ways in which we have structured the core curriculum, the one that I was talking about previously, is to link it to some of the curricula that are offered here. For instance, if you're dealing with a patient with a GI bleed, then you learn how to place a nasogastric tube and a Foley catheter, etc. This is the American College of Surgeons Association of Program Directors and Association for Surgical Education Resident Prep Curriculum. This is typically offered through your curriculum director for those students who have already matched into surgery, and it is typically offered after the match, but prior to you joining the surgical residency. A lot of students had questions in our last webinar as to how they can improve their skills prior to entering the surgery residency. And this is a curriculum that establishes exactly how you can do that. It covers various didactic topics, radiology, films, skills, how to answer a page, etc. And these offer practical guides and tips as to how to become a more effective surgical trainee starting day one. This is not accessible to you, but it is accessible to your clerkship. And so you would have to go through your program director or your clerkship director, or if you have a special skills director, to be able to access this curriculum. One of the other curricula that is offered actually to surgery residents oftentimes after they have matched, and this is through the program directors, but it is now available to all medical students for a limited time until May 31st, is the Introduction to the American College of Surgeons Fundamentals of Surgery curriculum. This is a case-based scenario, and these are the various cases that are available. It is interactive. So it takes you through a decision tree for diagnosis and management. And this is really a very good curriculum in order to help you develop your patient management skills, and is on an interactive basis. With that, I'm going to conclude my section and pass it on to the next presenter.
Great, thanks, Ranjan. And I'd like to stress to everybody out there that Dr. Sudan was critical and was the leader in developing all of these curricula for the medical students, and spent several years developing the needs assessment and also formulating the committees to fulfill these curricular objectives. I'll also like to say for the those second and third year medical students out there, the American College of Surgeons has a special website for the medical students, and particularly from our committee, we've put some PowerPoint talks about basic things that surgical medical students should know, things from how to round, what you should carry in your white coat, how to look at all the different types of instruments, and even after you match, what should you be doing between match day and July 1st when you start your residency. The final segment of our talk will be given by Dr. Choi and Dr. Schnartz, who will give their perspectives from a program director's point of view.
Thank you very much, Dr. Yang, and all the previous presenters have set us up very well for our discussion. I will say that to go off of some of Dr. Moore's comments, the sub-internship is extremely important, particularly for those who are about to start their interview process. As program directors who will be reviewing your applications, we recognize that some of those sub-internship experiences will look a little bit different, either based on the amount of time you've spent in those sub-Is or in the breadth of patients that you're able to see, since not everyone's operative schedules is quite as packed as it generally is this time of year. But we want to encourage you not to let COVID-19 negatively impact your work ethic. Dr. Moore mentioned the importance of presenting yourself well to your letter writers, but also presenting yourself well to your team. And as program directors, one of the most important things that we look for in an applicant is evidence that you're a team player, that you're going to work hard on all rotations, the ones you like and the ones you don't like. So we like to see some consistency in performance. We love it when we see letters that say that you are engaged with case management and physical therapy and really got to know your patients really well, because I think that demonstrates a lot of emotional intelligence. It demonstrates humanity. And so there are many aspects of your overall performance, hopefully not things that cause you worry and concern. Hopefully they're part of your natural abilities, but also things that if they aren't part of your natural abilities, that you're willing to work on those things. So we want to emphasize that COVID-19 is going to impact your experience, but it does not need to impact your work ethic. And so definitely get to know surgery during these next few months. Make sure that it's something you're definitely committed to, because we also want you to be really confident in your specialty choice. The other thing I would like to add from an elective experience is that, you know, you're going to spend some of this time in the summer doing electives or sub-internships in surgery. But I would highly recommend during the rest of the year that you really utilize the time to do some specialty rotations such as pulmonology or cardiology. Make sure you do a critical care month. Make sure you take some call in all of those rotations, particularly their surgery rotations, again, to make you very well prepared to be a surgery resident. So your whole year does not have to be surgical rotations. We're going to teach you surgery once you get here. We actually want you to spend some time learning a few other things. So Dr. Schnartz, what do you have to add under that bullet point?
So in that bullet point, really nothing. I think you really hit it. I do think there may be a minor point, and that is I think most program directors want to see that you've had at least one pretty rigorous surgical rotation so that you don't end up as a surgical intern surprised with the rigor of the experience. So otherwise, I think, Jen, what you said was absolutely spot on. I think Dr. Jesse Moore did exactly the right thing with away rotations. I think there may be a couple areas, as he said, where it might be useful to do. So for example, if there's a rotation that you don't have the ability to do at your medical school, let's say high-end transplant or cardiac surgery, and that's a particular interest, then yeah, have at it. But I think as a program director for a good number of years, you know, rotating at my program or rotating at another program really didn't enhance your ability to match there. In fact, in some ways, it really diminished your chances of matching because I think you really, if you go away to somewhere, you're going to be having trouble finding where the men's or ladies' room is, and you know everybody else is running to the OR. So I think sometimes I agree it can work against you and fully exploit what you have locally. The one area that I would say that Jesse didn't cover, which I think from a program director's standpoint is important, and this will be for the rising fours, and that is the personal statement. Take some care and write your personal statement. It really should only be a page. And it really should, it's you speaking in an uninterrupted manner. So if you have a blemish on your record that you want to discuss, that's a good place to do it. You can explain yourself. I, for example, lost both my parents as a third-year med student. So I got to explain why there was a little bit of a gap in my application personally. You know, so if you have a good story to tell, definitely that's a good thing for a personal statement. Have some people read it over, make sure the grammar is proper. I'll tell you just on a personal note, the personal statements that start with, I didn't know what I wanted to do with my life, and I ran to the trauma bay and saw somebody in a car wreck, and my life was changed forever. That really doesn't move program directors because that's such a common story. Make the story your own. And I guess I'll talk about the holistic application too.
I'm going to add one thing to personal statements.
Yep.
I think 10% of personal statements are really good and 10% are really bad. And so I would, if you want to be at least in the middle, if not on the awesome end. But the people that tend to not have other people read for grammar and punctuation, those are ones that you worry about attention to detail for sure.
Yeah.
So we're looking at different things, not just the words on the page. It's very interesting to be a program director and to read a whole application beginning to end, but those details are certainly important.
Do you want to do the holistic?
Sure.
Okay.
So either way, I want to point out that program directors, Jesse gave really great data from the NRMP. And so I think that those factors have to be taken seriously as far as how people look at an application. Every program director is going to look at an application differently, and they're going to look at an application based on what their program does, how it functions, what they expect of their trainees, and how their hospitals are set up. So there are many reasons that we look at different things in an application. And so with that, everyone's going to have some different strengths. Program directors are very dedicated to holistic application review. It's a process that some of us are still learning, some of us have excelled at, but I think everyone is ready to do that. I put step 2 in this bullet point because many programs do require step 2 to apply to their program. I can't speak for every program, but this year we understand, again, based on COVID-19, that the Pearson Centers currently are still closed, that there's going to be a backlog of people to take step 1 and step 2. And so I anticipate that there will be some grace in having step 2 as being a requirement for your application.
So I'm going to add in a bullet point here that after the holistic application. So and this is really for the more junior students who have joined us this evening. I think a very common question is, what can I do to enhance my chances or at least broaden my experience to see if surgery is a good fit for me? So I think there's a few things that you should consider doing. Number one, find yourself a mentor or an advisor, even as a first or second year, is usually very helpful. You'll find this is an area, I think, where the clerkship directors can be very helpful in pointing you in the right direction, so you can get some advice. I think the second is you can control what you can control. And so the things that you can control as a more junior medical student are your grades and your approach to USMLE and how you develop resilience and stress management. And the final thing I think you have control over is what sort of experiences that you can have. Jesse mentioned shadowing, which is a nice way to see if it's a good fit for you. Research, one of the best shadowing and even research experiences might be to go out into a smaller community. and learn how they do things there and bring them back. We've had a number of students do that in Nebraska over the years. And so I think, you know, if you can control what you're doing, makes a big difference. Now, I'm going to shift a little bit now to virtual interviews. So you guys may think that the virtual interview concept is a result of the COVID, and that really is not entirely true. Interviewing as a medical student is an expensive proposition. To be very truthful with you folks, you don't really get a chance to go around and see the city and the neighborhoods and things like that, because you're really flying in, meeting the residents and leaving. And so program directors have been considering the virtual interview just like businesses have for years. And, you know, there's still a lot to be determined on this. There's some very unique ideas that are coming to the forefront, such as having a Zoom, you know, social hour with just the residents, so you can interact with them and so you can see whether you like them, whether they like you, are you a good fit. You know, the AAMC has some best practices for their interviewees. This will be a challenging time. This will be new, I think, for everybody, but the idea of doing this really predates COVID a little bit. COVID had just really forced our hands. So I think that's all for our program directors' perspectives, and I think we'll turn it over to Dr. Yang, who will. Oh, sorry. I'm going to turn this over back to Jen because she knows these web pages better than I.
So, hang on one second, Alex. So I want to just add 2 websites that are really important. The first is the NRMP website. This is a place where you can put in your data and look at kind of your probability of matching in a surgical residency program. So it allows you to put in scores, your number of volunteer activities, your number of research activities, and things like that. And it should give you the likelihood that you will match. The second one is called Residency Explorer. And this is actually a tool that is put together by the AAMC, the NRMP, the ACGME. So a number of high quality organizations are involved in Residency Explorer. And again, you can put your data in and it will kind of show you what programs you would, again, have a high probability of matching at. And this is a really important tool because I think it exposes you to programs that you might not otherwise be exposed to. So Dr. Moore talked about being more confident about what's in the walls of the hospital rather than the name on the outside of the hospital. And so I think that this program in particular will help open you up to some of those other institutions that you may not be quite as familiar with, that will be great residency training programs, but are a little bit less well known. So 2 tools that I would really encourage you to take a look at as you are in the process of applying.
Great.
And that's
Thank
it.
you. Okay. Thanks, Drs. Choi and Schnartz. Okay, now we go to the fun part of the evening. We'll answer questions. We know initially the webinar was scheduled till 9 o'clock, but I think we're going to go probably till 9:30 to answer all of these questions. So again, a couple of you have been sending some great questions through the chat line. Some have been sending some comments to me personally. We'll try to get to some of these. So, one question that came up, Dr. Moore, so I think in your talk you had mentioned something about taking step 2 later. So after a good step 1, when is the later good?
So my point there is mostly that you can, if you've got a strong step 1 score, you can really focus on getting those acting internships done in June and July and August even, and you can do your step 2 in September, potentially as late as October, again, with that understanding that you may not come back in time for it to go in with your application. But if you have you know, a 248 or a 250 on step one, you're going to clear the hurdle in terms of most program directors who use step one as an initial sorting tool. You're going to end up in the pile of, you know, let's look at this application a little more. And the fact that you don't have step two yet, if you took it in, you know, early October, is probably not going to hinder your chances of getting a holistic review of your application. You can also, remember, you can always update your file later. So that's what I mean, is that you can do it, you know, September, October.
Okay, great. And then sort of a follow-up question to that. What are you all considering an above average or a strong step one score?
So you know, that is, you can hear me, right? This is PJ. That's always a very interesting question, because every residency has its own score. My understanding of the data is that 230 is about the mean. So above 230, I think you're usually in pretty good shape. Below 230, you might have some challenges. But each place has its own score level, and as we move to pass fail, that's going to change. So for the more junior medical students, as USMLE step one moves to a pass fail, which will probably happen in your term, not so much the second years now, because I think there's a year gap. That will be more, your other experiences, I think, will be more important. But for right now, I think 230 is what's considered the mean.
And if you can play with that, the interactive NRMP tool that Dr. Choi just showed, that'll really help you figure out where the cut points are. I usually think of 220. If you're below 220, that's a weak score. 220 to 230, it is going to depend again on what your goals are. If you're looking for super academic, high-powered, NIH-funded, you know, you want to be the next chair at Hopkins, you know, and beat Dr. Yang to that spot, then, you know, you better be above 230. You probably better be above 240, but it really, you have to think about your goals here. And being academic at the biggest place with the best name, that doesn't necessarily mean, that doesn't equate with success or happiness down the road. So you really have to figure out what you want for your career.
So I might add to that, Steve, if I can, to Jesse's point, which is a good one. You know, many of you listening in the participant pool here, you know, went to university of such and such for your undergrad, maybe even university for a master's, and now university is something for your medical degree. There are some really excellent non-university programs, and there are some dog university programs, and vice versa. It really has, it has to do with the teaching. The name of the institution, you will find as you interview, really doesn't carry all that much weight, because with the exception of some very isolated areas, you know, you as a resident don't go into the biochemistry lab and et cetera, et cetera. What you're really there is for the tertiary medical care. And so, you know, you don't have to be at a university, you don't have to be at a non-university. You know, to give you an example, in my field in trauma, the residency in North Carolina that produced the most trauma research and had the most grants wasn't Duke, wasn't UNC, wasn't Wake Forest, wasn't East Carolina, it was Carolinas Medical Center. And so, you know, there are some great non-university programs and there are some great university programs. And I would look at both as you sort of try to explore your way through this. Because both to a great extent, both can get you where you want to go. It depends on what's a good fit for you.
Thanks. So I'll refute Dr. Moore's comment that I'm not sure I could get into medical school these days with my aptitude testing, and you don't need to have that high a score to be chair of surgery, but that's not a negative thing about the chair here. So
And we've even seen Jen Choi's son, Spencer, join us. So
yeah, I had a question for him. He's rapidly disappearing. Well, speaking of research, Dr. Schnartz brought up, there's a couple questions on, A, how important is it? B, if you're not particularly interested in it, should you do it? And C, how much should you emphasize that on your application? Panelists?
I think I can take that, at least from applying to our medical school or our residency. Research is very important. So ours is a 7-year residency program, so you should know that up front. 2 years are spent in the lab. So if you are not interested in spending those 2 years in the lab, you probably shouldn't be applying to our program. And there are other such similar programs where there's dedicated research built in. There are some programs where research years are optional. So if you're not sure whether you want to go into research or not, those might be a better fit for you. And really, I think having a research background with some publications is definitely helpful when you're applying to some of these academic programs that have a dedicated research track. But I think really what's more important is for you to identify what PJ had said in the beginning, whether you're interested in an academic career or whether you're interested more in a community practice. If you're interested in a community practice, then going to a community medical center may actually suit you much better. And under those circumstances, having had a research career won't hurt you, but it doesn't necessarily help you all that much either. I look forward to the other panelists with regards to what they have to say about that.
I think from my standpoint, I don't care what you do the research in. We used to have a mandatory research year. And to be honest with you, I thought that was great because A, it gave our residents an opportunity to get some publications, but it was also a nice break in the middle of residency to reconnect with family, reconnect with friends, have children, etc. So, you know, the research year is not necessarily a bad year. You don't have to be any place at any time. To me, at least, when I'm looking at applicants, the research is interesting to me only because it demonstrates academic curiosity or intellectual curiosity. And I really don't care what you do it in. You can do it in, fragility and elderly cardiac patients. It just really shows that you're interested in something else besides, being a unidimensional surgeon. So I always like to see it if it's there. It's not a deal breaker if it's not. But it's something I think I like to see at least. I don't know about the other panelists.
So my take on research is that it is a part of the application. And I think that it demonstrates an investment in your future. It does not have to be research in surgery. And I want to say that I equally value volunteerism and leadership in many ways, depending on the research. And if you're doing it just to add to your application, I don't think that's worthwhile. I think that it's important to demonstrate, again, investment in your future. And for some people, that is leadership. And for some people, that's volunteering. I love to see people who have volunteered for a long period of time in the same thing. So if you've been a big brother or a big sister for 3 years to the same child, then I actually think that's equally important to doing some sustained research activity in some ways. So I think there are many ways to shine in an application. Like Dr. Sudan said, you have to tailor your applications to the right institution. So for some place that is heavily focused on research, then certainly research should be an important part of your application. The other thing is that from the, I think research gives you something to talk about in your interviews. So definitely, if you put research on your application, make sure you know what your role is in that project. And then we also like to see research that comes to publication. So when it comes to starting a project at the beginning of your 4th year, again, I think that adds something to your application. It demonstrates intellectual curiosity. But whenever we think about research that counts in many ways, publications are also important.
There's a paper out of Albany that looked at this and queried programs and looked at the impact of research, and it supports exactly what everybody has said, which is that for those programs where there's a huge focus on research, well, no surprise, they look at research as an important factor. But otherwise it's not. And I share the opinion of Jen, which is to say, do something that you're passionate about. You know, it's gonna, your application will read very differently if you've got, you know, 2 or 3 years of dedication to something that you're passionate about, and it's education, it's leadership, it's volunteerism, and you can talk passionately about that and what you brought to it, maybe a way that you had an opportunity to do leadership in that field, as opposed to having, you know, a 3-month, I participated in a research thing that, you know, didn't yield anything, but you can put that you did research for 3 months on your application. That just, program directors can read through that and they can see that that was an attempt to get some research onto the application. So go with something that you're going to be passionate about and have fun. Don't do it just to check a box.
And I'll also add that, you know, surgeons are innovators, and, you know, you always have to ask that question. So, you know, I think classically, a lot of students think research is going to the lab and running a bunch of blots or doing a large randomized prospective clinical trials. And obviously, you can't do any of that as a medical student. So you find something that you're passionate, as some of the speakers said, and just ask a question. You know, if it's never been done, write it up. So you do need to have a bit of an inquisitive mind. So it's not just a box to check off, but, you know, something that you have to have passion for, something that you've queried, something unusual, case reports. You know, that tells the program directors, you know, this person really is a get up and go person. You know, they're sort of thinking beyond sort of the everyday. So I think research is important, but again, if it's not your shtick, then leadership or some other activities, and you can always write about those things as well. It doesn't have to be a classic research paper, but it could be just a review of what you're doing. And since we're speaking about the research part, you know, some students are concerned about getting these letters of recommendation before the ERAS deadline, even though the deadline has moved on. So the challenge, again, when, you know, we have a few students online tonight who are worried about getting letters of recommendations because they're not able to do the sub-Is before the deadline. So what are some potential alternatives?
So I think one of the potential alternatives, and this will be contrary to my good friend Jesse, is if you don't have the opportunities to do, you know, an AI, or you've had a good exposure to the clerkship director. I think the clerkship director or people you meet on the clerkship, particularly in this day and time, are good. Another letter of recommendation that frequently gets asked about and is fairly controversial is, do you need a chair letter from your chair? Our chair, where I'm at now, he likes to write letters for the students. He likes to advise the students, though he has never worked with the students. And in my experience, at least, many of the chairs have never worked with the students. But they do like to sit down and meet the students and are willing to write the letter. So if you have a chair like that, that's a good alternative. You know, I know in the two chairs I've worked in my careers, but both of them really wanted to sit down and meet the students and really wanted to write a letter of recommendation on their behalf. Now, that's just an N of two, so others on the panel may have different experience with their chairs. Don't feel obligated that you need a chair's letter. I think most of us don't really look at that as particularly important, but I know for the chairs and the students coming out of their departments and into residency, that's another option for a letter, and a lot of them really want to sort of, if you will, vet you on the way out or help you along.
I don't disagree with that. I think that this is the year where, for sure, there's going to need to be exceptions to the general rules. And so I think that if some of our participants are in a situation where their institutions aren't going to be able to open up and get them back into the clinical environment until September, October, then they are going to have to do alternatives. Sit down with a chair is a good suggestion. I think that is a situation where you are going to have to think about using letters from your clerkship director or from a faculty member that you worked with extensively during the clerkship. And I want to reassure you again that all of your medical schools are aware of these challenges, and that dean's letter, that MSPE, is going to have in the introduction to it for every student from your school. It's going to say, these were the challenges that we had, and these were the institutional decisions that we made that had an impact on your students' abilities to do rotations. So program directors aren't going to just say, wait a minute, why are there no letters here? They're going to say, oh my gosh, this student is coming from a place where they couldn't get back in and do a rotation until September. I get it. I understand why this is different than I would normally see. So you've got a lot of allies in this process.
I'm going to ask Dr. Sachdeva a question. A significant number of our students tonight are actually trying to decide whether surgery is right for them. And so what would you say to them, Dr. Sachdeva? And also, along that same point, how would they go about looking for a mentor to help them with their career in surgery?
Well, I think people need to follow their passion, and the exposure to surgical mentors early has quite often decided the issue for them or has worked in favor of people going into surgery. If there isn't an opportunity to work with surgeons as closely given the current pandemic, then I think the students need to look for a mentor, an advisor. And I look at mentoring in a very special way. It's a very intense long-term relationship. Perhaps advising would be a better term to use, but they need to look for someone and sit down with that trusted individual and chat with them about their career aspirations, why they want to go into surgery, what the opportunities might be. And I also believe not every surgical specialty is the same. It's a very different lifestyle if you're a trauma surgeon versus, say, somebody doing breast surgery or endocrine surgery or colorectal surgery. So each specialty has its own unique characteristics, opportunities, and challenges. And I think one needs to sit down with that mentor or the trusted advisor to go through some of that. Our division has been looking at some sort of a national mentor matching program, which we've discussed with Dr. Yang, but it's not quite ready yet. If you need some guidance about how to connect with a surgeon, please contact us and we'd be delighted to help you. On a very personal note, I decided to go into surgery when I was 10 years old. I went into medical school wanting to become a surgeon because my dad was a surgeon. And I accompanied him once to the OR on a Saturday evening when he went to do an appendectomy. And that did it for me. I decided that was the only life I would select. So I think each one of us has our own stories to tell, but please follow your passion, because anything that you love and you enjoy doing is what you're going to be successful in. Thanks.
Can I make a comment, Steve? And that is, medical students are unusual beings in that you don't have to, you feel the need to get everything set up right here and now. You can change your mind, guys. I started as a pathologist before I was a surgeon. And so, the guy who works at Chick-fil-A doesn't have a crisis of conscience when he goes to work at Walmart. And so if you start down a path and you find that it's not a good fit for you, it's not the end of the world. You can change your mind either into surgery or out of surgery, but certainly preferable if you can to get that sorted out before you get there. But any experience you have in life is going to be a good one. So, if you're first, second, or even third year student, you haven't figured it out yet, take a breath, take some time, find some mentors and get to figure it out. But, you don't have to have your whole life figured out in the next, 30 days.
I'd offer, I agree with Dr. Sachdeva. The real value of mentorship and is critical. And I want to plea with you to listen to what residents have to say, but I also want you to just take it with a grain of salt. And remember that when you are thinking about a career in surgery, residency is a means to an end. And you're going to hear a lot about surgical residency and how hard it is. They're going to be tired. They're going to be disgruntled sometimes. And they're often only able to see kind of what's right here in front of them. It's a perspective, and it's an important one, because you do have to get through surgical residency to get to the 30-year career on the other side. But it's that 30-year career that you have to decide if you want. It's not the residency training. So find opportunities to talk with people who are 5 years out of practice and can remember what it was like to be a resident. Find people that you can talk to who are 10 years, 15 years, 20 years. You're going to get really different perspectives on what it's like to be a surgeon from each of those people. And I think that will help you understand more what it means to be a surgeon than if you just listen to the residents who are in the training process. And then finally, I think COVID has changed, obviously, your access to those people who are at your institutions. But a lot of institutions have developed online ways to do things like surgical grand rounds and morbidity and mortality conference. And the nice thing is that actually makes it more accessible. So you can contact the administrator in your department who's setting those up and ask to be included on the emails and the Zoom invites. And there's an opportunity to listen to how surgeons solve problems or approach things. And that may help you start to be part of the community and learn a little bit more.
That's all great advice. Just some other pathways of finding mentors in addition to what everybody has already said. I'm sure every institution has a surgery interest group. You can always start there. I'll sort of speak for the panel. I'm sure we know a lot of folks in the country. So you can email me, email us. I'm sure we can hook you up with somebody. But there's many ways of finding a mentor. And so starting with your own medical school, word of mouth, surgery interest groups. I think even most of the chairs or chiefs of the divisions would be interested in helping you through. This time, sort of tying the research part together is that there's not a lot going on in the operating room, and we're actually getting a lot of research done now. I'm an education editor for one of our major cardiothoracic journals, and our submission rate is up 25%. We're just overloaded. And most of it is COVID, but I think people are getting their research publications done now. there's a question. It sort of goes into, on the poll tonight, some people are, actually a large majority, have some questions about the different training paradigms. I can take that from a subspecialist. Traditionally, most students would go into general surgery and then differentiate into some of the other subspecialties. Cardiothoracic, vascular, pediatrics, critical care, colorectal, surgical oncology. And so, these days, some of these subspecialties have what's called integrated pathways. So the traditional pathway would be to do your general surgery, and then you go on to do a fellowship 2 to 3 years after that. But there are some integrated pathways, cardiothoracic, vascular, plastics. So you match directly into those training programs right from medical school. Traditionally, the other subspecialties, otolaryngology, neurosurgery, urology, orthopedics, there's one more, plastics. Some have their own departments, but they also have their own direct pathway of matching into them. And there's also another question about, whether you should be a procedural specialist or a surgeon. And I guess this is more for cardiac surgery. Well, as people have mentioned before, I think it's good to keep your mind open. Surgeons these days should be fairly well trained in doing everything. Cardiac surgeons in particular, yes, they sort of lost doing interventional cardiology and cardiac catheterizations, but it's coming back into the subspecialty now. It's called structural heart, where you're able to do the stents, you're able to do the transcatheter aortic valves and mitral valve replacements. So they are in a bit of competition with the cardiologists, but these days, as we had sort of mentioned before, you work in teams. So cardiologists are working with cardiac surgeons. So what's the difference? Well, I think a little bit is lifestyle, a little bit is what you want to do with your life. And so I think, again, it's going to be a little bit difficult at this stage in your game. Should you be a proceduralist or should you be a surgeon? Obviously, my bias is to be a surgeon because you can do all those procedures. So for thoracic surgery, I do some of my own bronchoscopies and navigational issues and stents and lasers, but there's sometimes I don't have time to do all of them. And so I ask our interventionalists to do that. Let's see, I think we'll probably just wrap it up.
Can I have for one? If some of the students out there are first years and they're trying to decide, do I want to be a proceduralist, meaning like a gastroenterologist or a cardiologist or a surgeon or an interventional radiologist, I think some of that depends on the lifestyle. Some of it also depends on the type of relationship you want to have with patients. And certainly in surgery, you can have differences in what that relationship is, but that's one way to look at that decision tree, is think about what kind of relationships you want to have with patients and over what time period.
Maybe we'll go back to one more question about the letters. So for instance, they're not able to do their sub-I this year. Is it important that it comes from the subspecialty that they want to be in, or can it be some other faculty that does their letters?
I think it's going to depend on what your relationship with that individual is. So, for example, if I'm understanding the question correctly, should all your letters be from surgeons? By and large, I think they still should be, but there may be a time, say you've done research with the geriatricians for some reason and spent a lot of time and demonstrated the passion and the, dedication to single focus. In those circumstances, it's okay, I think, to have a surgical letter, but I still think they're going to be looking for a surgical letter unless there's a really good reason not to.
I was just going to add that the letter should come within the general surgery specialties if you're applying to general surgery. So it doesn't have to be only from a surgical oncologist if you want to do surgical oncology, but you can use vascular, cardiac, all those kinds of letters for a general surgery application.
Okay, well, it's getting close to 9:30, so I thought we would just wrap it up. So I want to thank our panelists tonight, and Dr. Sachdeva and their staff for putting this on. I want to make sure for the students that you fill out the exit poll as we finish up. We want to get some good feedback, and I hope to put some more of these seminars on again. So you've heard a lot of great advice from national leaders in surgical education this evening. Surgeons, if you're still trying to figure out whether you want to be one, I believe are the best in finding solutions under adversity. We do this daily in our patients, in and out of the operating room. And even this slogan here, Strong for Surgery, is the American College of Surgeons program to enhance the health of our patients preoperatively. I think it's also a great theme for all of us facing these pandemic challenges. We hope to see you all personally at the Clinical Congress in October, which will be in Chicago. Where we have a great 3-day medical student program planned for you. Some of the people on the call tonight have been helping me plan the committee. On the committee have been planning this program for you, and many of the topics we've talked about tonight will be on that. So again, please fill out the survey, stay healthy, stay safe. And again, I want to thank our panelists for taking the time out tonight and the ACS for hosting this event. And to you, our audience, for a great interactive session. Good night.